Professor Brand, can you describe what is the personalized medicine?
Yeah. At the moment, the classical medical approach is that on the one hand, of course, we embrace the patient and the citizen as a personality and as a unique human being, but we always try out to find groups of patients where we make pharmaceutical testing, try out therapies to get a little bit closer to what really helps. Since a decade now, we have, let's say, the hard and software description of our population via this genomic sequencing, and parallel to this, big data allows us to analyze this data. And when we combine this then with the participatory approach of the patients, suddenly we have the possibility really to find out what helps the individual. And not only what helps, but what to avoid too. If you take in consideration that, for example, only 30% of the chemotherapy works in each patient, and you never know if will you be one of those 30%, it makes totally sense to check before you get this therapy if you would be benefiting from this. The French do this, for example, and every cancer patient there is sequenced, and by this they could identify those patients who do not profit from a classical chemotherapy, so that was not needed, and they could spare a lot of suffering for the patient and save a lot of money for the health system. So the cost-benefit analysis showed that it's very useful to do this. Personalized medicine does not automatically have to increase costs.
Why the molecular diagnosis is so important?
It's the program code that we run on. On the one hand, you have, like on a computer, the hardware, the genes, but then when you do this genomic sequencing and look more into the function of it, it's about the software. And we see there that, for example, of course, environmental influence is there too, but it's the first time that we have the possibility to really see how your body will react to different stresses and risk factors from the environment.
What are the obstacles to involve the personalized medicine?
On the one hand, it's quite new, so we are in the beginning of a long journey. It was very expensive when you remember the times when the sequencing was nearly unaffordable, and now we are much cheaper, and we see that it will be a routine test in several years. So we have the unique chance to prepare for the future, and that is one of the obstacles too, because people at the moment want to see the evidence, and this will take some years to really consolidate, but we can prepare for the future. And we should do this, not saying, okay, we will react on this when we know everything. No, it's foreseeable with this big investment that's going on and this technology-driven, that we have to take precautious measures how to integrate this in a good sense into our health system.
But we know any solutions for that?
What we see, for example, that only national approach to this will not succeed. We need big numbers of patients to find out what's going on. The solutions can be developed on greater cohorts much better than that we have now. So a cooperation, for example, in Europe between the European member states would really make sense. At the moment we see, for example, that the pharmaceuticals to combat hepatitis C that are very expensive challenge the budgets of the European countries. So it's not about personalized medicine, it's a traditional health. And here we see that suddenly member states themselves say, okay, we have to join together. 26 of the 28 member states joined the joint procurement for vaccines. Benelux was reinvented. Belgium, Netherlands, Luxembourg, they want to buy pharmaceuticals together. Romania, Bulgaria want to negotiate together for hepatitis C drugs. So what we see now is a bottom-up movement that perhaps Europe should unite in this case a little bit more to save money and especially to bring access to the people.